Your moderator for this evening's recorded event, Dr. Larry Patterson from Crossville, Tennessee.
We all treat astigmatism, and we've touched on this. How does it help us using these instrumentations, determining the difference between regular and irregular, and how does it affect us, Cynthia?
That's a great question. Astigmatism, I think, is a very difficult concept to explain to patients. They really don't understand it, no matter how hard we try to explain it. And so I rely on my OPD3 map, the axial map. If there's a bow tie, I say, do you see the bow tie? And I say, oh yeah, I see it now. It's usually in beautiful color. I say, it's this way or this way. I say, that's your astigmatism. They start to nod, and I say, therefore, a toric lens may be the ideal option for you because this bow tie is really big. Whereas if it's irregular and its color is all over the place, then we talk about that they are not or may not be a good candidate for a toric IOL.
Anyone else have any pearls on trying to explain astigmatism to people, including using this technology?
I mean, in our room we have 2 screens with our EMRs, so it's really easy. So we'll put the OPD3 up. If I'm thinking about doing a toric lens, we try to avoid a lot of medical jargon in our practice because obviously it's a lot of chair time. But if they really ask, I get an engineer type personality. I'll actually show them we are going to remove this on the right. That's the lenticular astigmatism. This is what's going to be left over. And I show them how they're crossing each other out or canceling each other out. And so I can show them this is what's going to be left over in very lay terms, and this is why we have to correct you with a lens implant that's similar to your natural lens, but unfortunately your natural lens isn't working anymore. And so that's how I do it in very lay terms. The other thing, objectively, not talking to patients, if you have irregular astigmatism, always think about EBMD, corneal dystrophy, epithelial basement membrane, because typically they will have some subtle EBMD or ocular surface dry eye, so always look for that too. It's nice to be able to show a patient the irregularity when you explain, like, you have a dystrophy, like, I never had that before. I go, well, you know, it's genetic, but I can show you it's creating a problem on the surface of the eye and has to be addressed.
And I noticed that we are doing a whole lot more surface treatments, just whether you call it corneal scraping or, you know, there's all kinds of words. We know what we're talking about. And being able to show people that picture, how irregular the thing is, we need to remove this bad tissue, let it heal. It's going to be a 3-month delay, but unless you just have a really severe cataract, it really would be nice to get it right that way. Any thoughts on astigmatism?
Well, we're doing a lot more toric lenses in our practices. And I think it's wonderful technology, but one of the things that we always wonder is, well, we have some residual left over. What happened? Did we accidentally not put it right on axis to counteract it? Did the lens rotate? What's going on? And what I love about the OPD is that it has an internal OPD map, and it shows me where the astigmatism of the lens is. And it can do it on a small pupil. Now, of course, we all know when you do a toric IOL, what is it? It's the patient that is on Flomax and the pupil's already coming down, so we can't even see the marks well to put the lens in, much less can we dilate them very well in the clinic afterwards. So this is a wonderful way to be able to sit there and have your printout that shows, okay, here's the vertical astigmatism on the cornea, but here is the horizontal astigmatism canceling it out on the lens. Okay, it's aligned right, the surgery was correct, so if there's anything that's left over, it's maybe I underpowered the system, or if I see it a little bit cockeyed, then I know that maybe I need to rotate the lens. But having that ability to see the lenticular astigmatism of the system really makes my life a lot easier because I'm not having to dilate the patients to do it.
I think the same applies to multifocal lenses or extended depth of focus. If a patient unhappy after surgery in the postoperative period, it helps you delineate why they may be unhappy. Is it the ocular surface? Is it corneal astigmatism that's remnant? As we all know with these more, the multifocal lenses, if you have even half a diopter of astigmatism, it could lead to unhappy visual results. So it really does help delineate where the kind of the source of poor vision or suboptimal vision is coming from, not just in the preoperative period and screening, but also in the postoperative period.